Mental health pharmacology is the study of medications used to treat mental health conditions. These powerful drugs can help manage problems related to mood, thinking, behavior. For the nursing student preparing for the NCLEX, understanding these medications is a fundamental pillar of safe, effective patient care. A nurse must know main drug classifications, intended effects, potential risks. This knowledge empowers the nurse to monitor patients properly, identify adverse reactions quickly, provide clear, life-saving education to patients and families. This essay will be your guide to essential psychotropic medications. Primary goal: simplify complex information for NCLEX success. We will break down each major drug class into manageable pieces. Focus: what you absolutely need to know for safe practice, why a drug is given, how it works in a simple sentence, and what to watch for. By mastering these core concepts, you build a strong foundation, anticipate patient needs, recognize warning signs, and intervene appropriately. Medication management is collaborative and requires vigilance and a compassionate approach to patient teaching. This journey uses simple checks and easy teaching lines. Let us begin this essential review and dive in. Selective serotonin reuptake inhibitors, or SSRIs, a cornerstone of modern psychopharmacology. Nurses will see these prescribed frequently. We give SSRIs to treat a wide range of conditions: major depressive disorder, anxiety disorders, obsessive-compulsive disorder, post-traumatic stress disorder. Common examples you must know for the NCLEX: fluoxetine, sertraline, citalopram. They are often the first-line treatment choice because they have a more favorable side effect profile compared to older antidepressants, making them a safer starting point for many patients. The mechanism is straightforward. SSRIs increase the amount of serotonin in the brain's synapses by blocking reuptake into the presynaptic neuron, leaving more neurotransmitter to bind receptors. This helps regulate mood, sleep, appetite, making explanations to patients simple and reassuring. Common side effects include nausea, headaches, difficulty sleeping. Another significant but often underreported side effect is sexual dysfunction, decreased libido, difficulty achieving orgasm. Create a safe space for discussion. Teach that many initial effects like nausea may lessen over weeks. Of greater concern: serotonin syndrome, high body temperature, agitation, increased reflexes, tremor, sweating. Another safety alert: increased risk of suicidal thoughts in children, adolescents, and young adults. Avoid mixing SSRIs with MAOIs. Use caution with tramadol and St. John's wort. These raise serotonergic risk. Nursing considerations: monitor mood and suicidality early and often. Educate on delayed onset. Reinforce adherence, review interactions, and escalate immediately if serotonin syndrome is suspected. Serotonin norepinephrine reuptake inhibitors, known as SNRIs, represent another major class of antidepressants. We give these to treat depression and anxiety, much like SSRIs. Dual action makes them effective for chronic pain conditions such as diabetic neuropathy and fibromyalgia. The two most common SNRIs, venlafaxine, duloxetine, helpful when SSRIs are ineffective. Mechanism: block reuptake of serotonin and norepinephrine, boosting both to elevate mood and modulate pain pathways. Study tip: remember the dual action. Side effects: nausea, dry mouth, excessive sweating, very important. Increased blood pressure due to norepinephrine. Routine BP monitoring is essential, especially with venlafaxine and duloxetine. Serious risks similar to SSRIs, serotonin syndrome and black box warning for increased suicidal ideation in younger populations. Monitor mood diligently. Unique consideration: withdrawal if stopped abruptly, dizziness, nausea, anxiety. Teach never to stop on their own. Follow a gradual tapering schedule from the doctor. Nursing summary: assess efficacy and mood, monitor BP routinely, teach side effect coping, reinforce adherence, and coordinate safe tapers. Tricyclic antidepressants, TCAs, are older drugs for depression, not first line due to side effects, but used for treatment-resistant depression, some sleep disorders, and certain pain. Examples: amitriptyline, nortriptyline. They block serotonin and norepinephrine reuptake like SNRIs, but are not selective. They also block cholinergic, histaminergic, and adrenergic receptors, explaining extensive side effects. Common anticholinergic effects: dry mouth, blurred vision, constipation, urinary retention, frequent drowsiness, often doze at bedtime. Serious adverse effects: cardiotoxicity, arrhythmias, tachycardia, overdose can be fatal. Assess suicidal ideation, monitor ECG and blood pressure, and use fall precautions, especially in older adults. Monoamine oxidase inhibitors, reserved for treatment-resistant depression. Block monoamine oxidase, the enzyme that breaks down serotonin and norepinephrine. Most serious adverse effect: hypertensive crisis triggered by tyramine-rich foods. Provide clear lists: aged cheeses, cured meats, fermented products like soy sauce, and some alcoholic beverages. This restriction is life-saving and non-negotiable. Nursing priority: education, review diet, interactions, and urgent symptom recognition. Coordinate with providers for safe transitions between antidepressant classes to prevent serotonin toxicity. Antipsychotic medications are primarily used to manage psychosis, hallucinations, and delusions, hallmarks of schizophrenia. Two categories: typical, first generation; atypical, second generation. Typical antipsychotics: haloperidol, chlorpromazine, most effective at positive symptoms, known for potent effects but significant motor side effects, requiring vigilant monitoring. Mechanism: block dopamine D2 receptors. Excess dopamine is linked to psychotic symptoms. Strong blockade drives side effects. Common sedation and anticholinergic effects: dry mouth, blurred vision. Most tested adverse effects: extrapyramidal symptoms, acute dystonia, muscle spasms, akathisia, restlessness, Parkinsonism with tremor and rigidity. Long-term risk: tardive dyskinesia. Involuntary repetitive movements, often face and mouth, can be irreversible. Early detection is critical. Most severe life-threatening effect: neuroleptic malignant syndrome, very high fever, severe muscle rigidity, altered mental status. If suspected, stop medication immediately and initiate supportive care. Monitor for EPS, check temperature and muscle tone regularly. Atypical antipsychotics: risperidone, olanzapine, clozapine, treat positive and some negative symptoms with broader receptor effects and lower EPS risk. However, serious metabolic risks: significant weight gain, increased risk of diabetes, high cholesterol. Monitor weight, blood glucose, and lipid panels meticulously. Special note for clozapine: agranulocytosis, dangerous drop in white blood cells, requires strict blood count monitoring. Mood stabilizers are primary treatment for bipolar disorder. The gold standard for mania is lithium, reducing severity and frequency of episodes and stabilizing mood long-term. Lithium has a very narrow therapeutic range, a small gap between helpful and toxic doses, demanding meticulous monitoring and education. Exact mechanism is not fully understood. It alters sodium transport and influences multiple neurotransmitters. At therapeutic levels: fine hand tremors, increased thirst, polydipsia, increased urination, polyuria. Monitor for toxicity: early, nausea, vomiting, diarrhea. Later, confusion, coarse tremors, seizures. Illness with fluid loss can quickly lead to toxic levels. Report immediately. Check serum lithium regularly. Therapeutic window 0.6 to 1.2 MEq/L. Monitor kidney function, BUN, creatinine, and thyroid function tests. Teach consistent salt and fluid intake. Dehydration or decreased salt increases lithium levels, while increased salt can lower levels. Long-term use can affect kidneys and thyroid. Other mood stabilizers: valproate, risk of liver toxicity, monitor LFTs. Carbamazepine, anemia and low WBCs, monitor CBC. Lamotrigine, black box for Stevens-Johnson syndrome. Teach to report any new rash immediately. Anxiolytics treat anxiety. Hypnotics induce sleep. The most well-known class is benzodiazepines: lorazepam, alprazolam, diazepam. Short-term severe anxiety, panic attacks, insomnia, used for agitation and alcohol withdrawal. They act fast, offering relief while SSRIs begin to work. Benzodiazepines enhance GABA, the brain's inhibitory neurotransmitter, calming the central nervous system. Results: sedation, reduced anxiety. Side effects: drowsiness, dizziness, decreased coordination, increasing fall risk, especially in older adults. Most serious adverse effect, respiratory depression, greatly amplified with alcohol and with opioids. Nursing considerations, use short durations as prescribed, assess sedation, monitor respiratory rate, implement fall precautions, and never stop abruptly after long-term use. Taper to avoid withdrawal, anxiety, tremors, seizures. Long-term alternative, buspirone, does not cause sedation, very low dependence risk, used for GAD. Acts on serotonin and dopamine receptors, works slowly over weeks. Teach patients to be patient and adhere. Reinforce adherence, avoid alcohol, discuss all medications before starting or stopping, and follow provider instructions for any tapering. Stimulants are the most common and effective treatment for attention deficit hyperactivity disorder. Purpose: improve focus, decrease impulsivity, reduce hyperactive behaviors in children and adults, improving function at school, work, and socially. Two main types, methylphenidate and amphetamine salts. Though counterintuitive, stimulants activate attention and self-control circuits by increasing dopamine and norepinephrine, critical to executive functions. They block reuptake and increase release, helping correct the neurochemical imbalance and supporting prefrontal cortex function. Common side effects: decreased appetite leading to weight loss, insomnia, increased heart rate and blood pressure. Often dose-dependent and improved by timing doses earlier. Nursing care: monitor weight and height, especially in children, to ensure growth is not suppressed. Serious adverse effects: sustained BP and HR increases, dangerous in pre-existing heart conditions. Perform cardiovascular assessment and ongoing vitals. As controlled substances, assess for misuse, dependence, and diversion. Teach safe storage and proper administration. Ensure medication is used exactly as prescribed for its intended purpose, with regular follow-up. When administering psychotropics, pay special attention to vulnerable populations. Many drugs cross the placenta, balance fetal risk versus risk of untreated mental illness. Some increase birth defect risk, e.g., lithium, certain anticonvulsants. Some cause neonatal withdrawal, coordinate OB and psychiatry. Elderly, reduced metabolism and clearance raise sensitivity, sedation, confusion, orthostatic hypotension, false. Start low, go slow. Advocate for lowest effective dose and monitor closely. Adherence matters across SSRIs, SNRIs, benzodiazepines. Sudden stops can cause flu-like symptoms, dizziness, severe anxiety, even seizures. Teach: never stop abruptly. Call provider, follow a safe taper. Universal safety alert: antidepressants carry increased risk of suicidal thoughts early in treatment, especially children, adolescents, young adults. Energy may improve before mood, increasing risk. Perform diligent suicide risk assessments and teach families to report worsening depression, new suicidal thoughts, or unusual behavior changes immediately. To ensure patient safety and prepare for the NCLEX, keep a mental checklist. Before initiating any new medication, baseline assessment is non-negotiable. Mental status, blood pressure, heart rate, weight, height, and pregnancy test if applicable. Memorize key labs: lithium level, BUN, creatinine, thyroid tests. Clozapine, CBC, WBC. Atypical antipsychotics, blood glucose, lipid panels, valproate and carbamazepine, liver function tests and CBCs. Ongoing monitoring, therapeutic effects and side effects, regular vitals, orthostatic BP for TCAs and antipsychotics, fall risk assessments, substance use screening, ECG for drugs with QT risk. Use short, simple scripts. Take this drug every day. Even if you start to feel better, it can take several weeks to work. Be patient. 2 essential warnings: do not stop suddenly without talking to your doctor, and avoid alcohol with this medication. Empowering patients with clear rules is highly effective. By mastering these checklists, you will be well prepared for the NCLEX and a career of safe, compassionate nursing care. For more information, visit www.brispainternational.com.